So I'm going to be speaking on rib fractures, and we're just going to go through the diagnosis and prognosis. So this lecture is split into two main populations. So firstly, we'll be looking at rib fractures in foals, and then followed on by rib fractures in adults. So foals, rib fractures are associated with parturition and are common in the neonatal foal, particularly in the thoroughbred. So starting with diagnosis, I guess the first thing usually is physical examination. So careful palpation of the rib cage should be routine in all newborn foals. So we usually check our foals when within the first 12 hours, and we always check their rib cage really thoroughly. And what you're looking for is any signs of crepitus, pain. Sometimes you see subcut swelling. And this is something then that we tend to follow up with imaging. Palpation of the rib cage doesn't tend to be very accurate, and you usually can often miss them. So if we're worried for whatever reason, we'll follow it up with further imaging. Other things you can see on physical exam will be some sort of thoracic asymmetry. So we see flail chest in foals sometimes that have multiple rib fractures. And other signs can be signs of discomfort. There can be numerous causes in foals, but sometimes rib fractures can be quite a common cause. Sometimes we'll see the foals, they'll be reported to be much quieter, lying down, not up nursing. Clinically, they'll look very well, palpate fine, and then on scan we can find some fractures. So it's something that we always worry about and always try to rule out in some of our newborn foals. Other signs as well in physical examination, unexplained tachycardia or tachypnea can be quite common causes or signs of rib fractures. So ultrasonography is probably our main main source of diagnosing full rib fractures. We tend to use a high frequency linear array probe, and usually all we tend to have is we tend to use our rectal linear probe, and we usually get quite a good image because they're very, very superficial. Usually start in the transverse plane and then move longitudinally. Always scan both sides as well, not just the side that you think that you can feel the fractures on, because often there will be maybe smaller cracks or fractures that can be missed or misdiagnosed. Scan all ribs individually, and then as far cranially as possible. You can usually get almost all the way through to the very first rib and some of the smaller folds. And then also we tend to scan the better side first and then scan the side that we think the fractures are on afterwards. It tends to be easier with the patients. And then the other thing to scan for is scan the rest of the thorax to check for any additional pathology that may be as a result of the rib fracture. So things we'll look for is pleural effusion, usually hemothorax, pericardial effusion, or sometimes we can see pneumothorax as well. So this is an ultrasound of a newborn foal that presented with reluctance to nurse, lying down a lot, not interested in the mare. And on palpation, we could feel crepitus along the rib cage on the right. And here you can see there's some free fluid coming in, there's some pleural contusions, and there's a nice displaced fracture here on the inside. I think this foal had maybe 5 or 6 fractures all the way back along, so there's quite a lot of free fluid. And as you scan back along, you can see there was some further damage to the lungs, so that's usually what we tend to see. This is the same foal, and you can see just over the heart, you can see there's a displaced fracture here, which is basically almost touching the heart, and you can just see a little bit of free fluid there also. So this is just another scan of a foal that was 12 hours old. It presented after the stud reported that it had been quite a tight pull. And foal was clinically bright, but on the external rib cage you could see some subcutaneous swelling, and you can see this on scan quite nicely. There's a nice hematoma formed around the displaced end of the fractured rib, and there is some mild, very mild pleural irregularities. This foal was just box rested and scanned weekly, and then at 3 weeks old here in the follow-up you can see that there's a nice callus has been formed along the rib, and there is still some pleural irregularities, but they were very, very mild, and this is what you often see once the callus has formed. This foal was turned back out, done clinically well, and no problem since. Something else then, so radiography is another way to diagnose fractures and folds. It's usually only for folds more so that are referred into the hospital, the much more serious cases. So the fractures are usually only evident if they are in the mid portion of the rib, but they can be quite useful for confirming pneumothorax, hemothorax, and the standing position, if possible, usually to help assess the volume of fluid. These x-rays can often be repeated when the folds are in, just to see whether there is any improvement in the level of hemothorax sometimes that's done. So this fold here is a fold that presented, I think it was 6 days of age, had been on farm, and it was known that it had some rib fractures, was being managed conservatively. 6 days later, it presented with tachypnea. So when it was admitted to the hospital, you can see there's a large area of pneumothorax here, and this is the image of the same fold then following removal of the chest drain after it was treated. CT as well is very, very useful in folds. It gives us a really detailed and comprehensive evaluation of the fractures and some of the other surrounding tissues. It's rapid and easily performed under sedation. Some of the newborn folds, just some diazepam, will keep them asleep long enough to get quite a nice scan. And alignment, perfect alignment is not critical, so we can just put the folds in, whiz them through the CT, and then we can get some really good images. So this fold, as you can see, this is the pleural side looking inside out, and you can see the displacement of the fractures, and they're displaced medially, and then the rest of the fractures are displaced laterally. And this is looking at it laterally, so it's the same image from the other side. This fold went on to have surgery afterwards, but just doing a CT before the surgery was quite useful and gave us some good information as to how to align some of the fractures afterwards. So in terms of management, we're not going to go into this too much, this isn't what this lecture is about, but you can either manage the folds conservatively or surgically. And this often depends on the case, how many fractures they have, and what other signs they have. So conservative treatment is often analgesia, box rest or barn rest, and then repeated ultrasound exams, particularly in the very early cases and folds that have quite a lot of hemothorax, just to keep monitoring them. And then surgical folds treated surgically, they're usually referred for more complicated cases. And it's not without its risks or costs, but these are folds that often tend to not be responding to conservative treatment, or folds that have much more serious secondary issues, such as like pleural effusion, or not, pericardial effusion. So we'll just briefly go into some of the prognosis in rib fractures and folds. So this paper just looks at thoracic trauma in folds, and it was just post-mortem findings. So over a 10-year period, they had 760 necropsied folds. 67 of these folds had thoracic trauma, and then they grouped the folds into 3 further groups. In 19 folds, they thought that the rib fractures were the cause of death. 20 folds had rib fractures that were incidental, and a further 28 folds had rib contusions that were also incidental. So it gives us an idea of how serious it can be in folds. So in this study, they found that ribs 3 to 8 accounted for 86% of the traumatized bones, and that's what we tend to see when we're looking at these folds or scanning them. And the most common area of injury was either at the costochondral junction or just the area above it, and it's the exact same when you scan it. That's always the area you feel, and you'll find those fractures in. All but 2 folds from the study died within the first 8 days, so it tends to be neonatals, newborn folds, and quite early in their life. And hemothorax and pulmonary collapse was the most common cause of death in these folds, 53%. So it's something to be very aware of with these folds, that sometimes we miss it, it's fine, but they can often end up dead with them as well. So when I was an intern here, I presented this at BIVA. So we looked, it was the future racing performance of neonatal thoroughbreds that were diagnosed with rib fractures in the hospital, and they were either treated surgically or conservatively. So over a 10-year period, we got the cases from ourselves here at Rossdale's and from Tri-Town in Kildare, and then we compared this group to a group of controls of other folds admitted to the hospital without any rib fractures. And the racing data then was obtained from the Racing Post and the racehorse.com. So our case inclusion criteria They were thoroughbred foals that were bred for racing. They needed to have been diagnosed with at least one rib fracture, and the fracture needed to be associated with parturition. So the management and progress to discharge. So we had 44 foals in total, and in the conservative group we had 27 foals. 2 of these foals were not discharged, and these were not directly related to the rib fracture. One was the disc mature foal, the other foal had sepsis. In the surgical group we had 17 foals, 4 were not discharged. One, it was unknown on the paperwork what the post-mortem findings were. And then the other 3 foals that died, they all had a rib fracture comorbidity. So one foal during surgery was diagnosed with diaphragmatic and small intestinal laceration. Another foal had diaphragmatic and colon laceration. And then the third foal had post-operative destabilization of the rib fractures, hemothorax, pericardial laceration, and cardiac arrest 8 days after it was operated on. But this foal obviously was quite severe and had multiple rib fractures. So of all the foals then that survived and were discharged, the 3 of the foals died prior to racing age. So one foal in the conservative group had a pelvic fracture, was not related to the ribs, and in the surgical group 2 more died, and again not related to the rib fractures. So in total 35 foals survived to 2 years of age, so 79.6% had the potential to race. Of these, 74% raced, and then 34% went on to win. So we're just comparing the 2 different groups. So in the surgery group and the conservative group, we can just see here that the surgical group had a much higher loss before reaching racing age. But then the surgical group, more of these foals went on to race and more of them went on to win. But looking at the p-values, none of these were statistically significant. And then we just compared the racing or the fractured foals to a group of controlled foals, and they were thoroughbred foals admitted to here at Rossdale's only, and no rib fracture was recorded. And we can see from this overall the number of foals that went on to race and win, and the number of foals that raced. So here we have the surgically treated group, 50% went on to race, and the conservative group nearly 60, and then of all the rest of the foals, again around 40%, but the p-value was 0.2, so not significant. And then the same with the raced and won. You can see the controls, it was quite similar between the control group and the surgically treated group, and a little bit less for the conservative group, but overall it was quite similar. So from this study we concluded that many neonatal foals diagnosed with rib fractures went on to race, and there were no differences in the measured race outcomes compared to foals treated for other neonatal issues. There were more losses prior to racing age in the surgically group, but again, they would have been the foals with much more severe fractures, and there was no significant differences in the earnings between the surgery or the conservative groups. So then moving on to rib fractures in adults, very, very different causes and very different presentation also. So the causes we tend to see are often blunt trauma, so kick injuries, falls, road traffic collisions. Other things we see are often gateway accidents, transportation issues. Another thing we see as well, we'll talk about a little bit later, is stress-related injury we can see in some of the young thoroughbreds. And then a lot of the time, the cause is unknown in these foals, or in these adults, sorry. They may be related to blunt trauma, but it's unknown basically. So again, diagnosing rib fractures in adults, palpation can be useful in certain cases. So cases that have presented for trauma, they can be quite sensitive. Some of the horses that present for ridden issues, sometimes palpation can identify an area of pain in the ribs. Usually ultrasound is really, really good. It's very, very sensitive and useful. And radiographic evaluation, it can be challenging. Soft tissue can obscure the cranial ribs, and then abdominal viscera makes evaluation of the caudal ribs quite difficult, but depending on where the fractures are, sometimes radiography can be really useful. So this was a 6-year-old Arab that presented at a hospital after, I think it had an incident with, in a gateway, and had a large wound over its left side of thorax. So scanning of the area was quite difficult due to the large wound. But we can see here there's 2 displaced fractures, which look really nicely just because they're sitting over the airfield. So sometimes radiography can be really, really useful and really helpful. One of the main ways we often find fractured ribs is using nuclear scintigraphy. So it's particularly useful, and it's very, very specific in identifying fractured ribs or maybe previously fractured ribs. So get the focal area of increased radiopharmaceutical uptake on the ribs. So there's a nice IRU here, a little bit here as well, and the next rib, same here again, and then this rib is quite high up. So you can see lots and lots of different rib fractures in different cases. This is a horse that had a fall out of venting, and here we can see on the dorsiventral view there are 4 really nice rib fractures just on the left side, so some nice uptake there. So it's usually, bone scan is usually followed up then by further imaging just to assess whether or not these hotspots are relevant, and it also, this will help ascertain the relevance in combination with the history into presenting signs. So some of these hotspots we find are often incidental, so I think it's important to put everything together to try and decide whether or not these are relevant. This is just an ultrasound picture of a horse that had just one hotspot on its rib and nothing else. I think it had presented with resentment when riding, and you can see that there has been a previous rib fracture, and there's a nice callus formation of the rib down along here. So this horse was treated conservatively with, I think, 2 months of box rest and then returned back to normal function. So another paper that Claire Wiley done while she was here was they looked at the clinical features of 50 cases of rib fractures in adult horses. So it was a retrospective case series over an 11-year period, and 50 cases in adult horses only were identified with the diagnosis of a rib fracture. So 40 of these 50 cases were considered clinically relevant, and within these fractures, 7 were recorded as painful on palpation, and 8 had a history of trauma. And the different presenting complaints that we saw when we looked at all of these cases were there was lameness, and just lameness in some of the horses between the grades of 1/10 to 6/10 lame, resistance when riding also in 32.5% of the cases, history of trauma in some of them, and then in one case I think there was just pain and palpation was the only presenting sign. So the imaging modalities that were used, ultrasound was used in 82% of the cases, and both scintigraphy and radiography used in 74% of the cases. So in total, from the 50 horses, we had 66 rib fractures. T18 was the most commonly fractured rib with 32.8%, followed in second place by T10, which was just 10% of the cases. Interestingly, or maybe not so, the left side seemed to have a much higher proportion of fractures than the right side, and multiple rib fractures were identified in 5 horses. And then from looking at this case series, interestingly, 5 cases of T1 fractures were identified, and these were only identified in racing thoroughbreds. All of these presented with an ipsilateral lameness, and this condition was unique to the racehorse and likely to represent a fatigue fracture pathology. And this is just one of the images of the bone scans from one of these racehorses. So we can see here there's some mild uptake on the first rib, and then when we mask out the costochondral junction, you can see there's quite a nice uptake on this rib here. So I think this horse was treated conservatively. And then just another BEAV abstract that was presented the same year as the other one was looking at rib fractures as a cause of discomfort or poor performance in ridden horses out of lip hook. So again, retrospective analysis of clinical studies over a 15-year period, but different compared to the Rossell's ones. These were presented with back pain, poor performance, and diagnosed with a rib fracture, and they excluded any cases of overt thoracic or abdominal trauma or systemic abnormalities. So these were looking more poor performance cases without any history as such of trauma. So they had 15 cases in total. The presenting signs were either bucking, bolting, or resistance to work. Back palpation localized the lesion in 3 cases, and all of their cases underwent scintigraphy that revealed IRU in a rib. And again, similar to the cases out of Rossell's, T18 was the most commonly fractured rib. They had 10 cases, and they had between the location was 10 to 15 centimeters lateral to the costovertebral junction, which looked like the area from one of the previous images looking down of that horse that had 5 rib fractures on the DV on bone scan pictures. So the follow-up, they followed their cases through. All the horses were arrested for 3 to 12 months before starting ridden work. 8 cases were available for a long-term follow-up greater than a year. 7 of these returned to the previous level of work, and 1 horse, which was treated surgically, was euthanized due to post-operative complications. So in concluding, just summing up everything, rib fractures should always be considered in certain orthopedic examinations where lameness or resistance to ridden exercise are problems. The ease of diagnosis is often dependent on the clinical presentation, so I guess it depends on what we're presented with and the history as to how easy it is to find the fractures. And then the prognosis tends to be relatively good if there are no other complicating issues. So some of the traumatic issues, they will often have hemothorax, different lung lesions, so more the poor performance issues, they often tend to respond quite well, and most of the horses respond quite well to conservative management. Great.